My name is Allison Stubbe, and I am a maternal fetal medicine physician at UNC Chapel Hill. And I want to chat with y'all a little bit today about reproductive justice in ObGyn. It goes without saying that I do not have lived experience as a woman of color. And so I come to this work with a tremendous amount of humility. And as I've been talking more about reproductive justice in the last couple of years, I ask the folks I'm speaking with, and this includes all of y'all, to please, if I misspeak or misstep, call me in preferably, or call me out as needed, because the only way that we're going to address the unacceptable disparities in healthcare and in the lived experience of folks in the United States is if we're all willing to learn and to be better. So I have my Twitter handle on this slide. Please DM me, reach out to me, email me, and let me know if there are ways that I can be clearer or better or be a more effective ally and advocate for folks who have been marginalized. So I want to start out by sharing some data that many of you are familiar with. There are immoral and unacceptable inequities in health outcomes for Black women and Black and minority infants of color in the United States. As shown here, the rate of maternal death is 3 to 4 times higher for non-Hispanic Black mothers than for white mothers. And when we look at infant deaths, infant mortality is 2 to 3 times higher for non-Hispanic Black, twice as high for non-Hispanic Black infants and for American Indian, Alaskan Native, and Native Hawaiian Pacific Islander infants. And I think it's really important to be clear that there is nothing about melanin or about African ancestry that increases your risk of dying. Biologically, race is a social construct. And so these differences reflect socially constructed differences in access to resources and access to care, and policies that have deliberately and systematically deprived folks of color of access to those resources. So if we want to fix this, it isn't about finding the gene that co-segregates with melanin that explains why Black folks have worse outcomes. It's about understanding the policies and practices that have led to these differences. So I want to walk y'all through some of that today, and then also include some really concrete things that I'm hoping you could take to your next patient encounter that can help you to deliver more equitable care. So I think it's really important to appreciate this concept of stratified reproduction. And this was introduced to me by an anthropology colleague about 5 years ago. And stratified reproduction is this idea that throughout the US history, the fertility and childbearing of poor women and women of color were not valued equally to those of affluent white women. This is a really important paper that goes through this in detail and talks about things like the treatment of enslaved Black women who were systemically raped by the folks who owned them in order to produce more slaves for the next generation, or the treatment of Native children who were taken away from their families to off-reservation boarding schools, or the coercive sterilization of poor women and women of color. Some of those things feel like they're from a long time ago, but I think when we think about the ways that reproduction is valued, I often think of the TV show 19 and Counting, which as obstetricians, I think we all kind of go like this when we hear about, I think she's on C-section number 10 or something at this point. But that's a white mama and a white family with a whole mess of kids. And imagine how network television would feel about the exact same narrative in a Black family with 19 children. And I think when you realize the visceral difference of that, you realize the way our society celebrates the reproduction of white women and denigrates and sees as a problem to be solved the reproduction of Black women. And we marinate in that world. It's around us all the time. And so we have to deliberately dismantle that in our interactions with our patients. So in recognition of this stratified reproduction and long history of injustice, in 1994, a group of Black women came together to conceptualize reproductive justice. And reproductive justice is a step beyond reproductive rights. So reproductive rights are often about access to abortion, access to contraception. Reproductive justice takes it a step further. It's the right not to have a child, the right to have a child, and the right to parent children in safe and healthy environments. So reproductive justice is about access to infertility treatment for folks without private insurance, or for folks who can't pay out of pocket, which is a real thing, right? That's a real problem. It's about the right to parent children in safe and healthy environments. So that's the right to paid parental leave so you can parent your child. It's the right to not having your male child shot for walking down the street in a hoodie with his hands in his pockets just because he's Black. So reproductive justice is a much bigger conceptualization. And so I think we can think about this in a really concrete way in your next patient encounter. So I was raised as an intern and resident, and med student for that matter, to make sure that on postpartum rounds at 5:30 in the morning, I shake the mom awake and say, what are you going to use for birth control? And that's an important question, right? That's on our checky box list. But let's consider how that feels to the woman who has historically been marginalized and led to believe that the health system doesn't want her to have more babies. You can shift that narrative really subtly. And instead of shaking her, well, first of all, don't shake her awake at 5:30 in the morning, come after she's awake, but have a conversation about, do you think you want to have another baby? And if so, when do you want to have another baby? Because that feels really different. That's about what are her goals and how can I support them, instead of what is my goal, which is to check off the box and make sure she doesn't have more babies. So I urge you to try that on. And it leads to some really great conversations, because sometimes the answer is never. And then I ask the question, so how are you thinking about doing that? And if she says withdrawal, then I can say, well, never and withdrawal, that doesn't really line up. But maybe she says, I'm 40 years old, I have 2 children, I've been with the same partner for 20 years, and the only times we got pregnant were when he didn't pull out. Well, then withdrawal is working for them. And we can say we've got some things that are perhaps less disruptive, but you do you. So I think it's really important that we center our counseling in the goals of the patient as opposed to our goals as the provider. And I think there's some really compelling evidence that patients feel that stratified reproduction. This was a paper in the American Journal of Public Health, and a Latina focus group participant said, birth control in general makes me really wary because it was meant to keep people like me from procreating and having more of us, right? I don't really trust doctors because I don't know what subconscious things are going on when certain methods are being recommended to me. So I urge you to preempt that, to get to know your patient's priorities, ask her what she wants, ask her what's important to her, and then have a conversation about birth control, rather than saying, what are you going to do to not have more babies because, y'all have too many of them. I think we also have to look at our processes of care. This is work led by Jasmine Johnson, who some of you may know on Instagram as Mrs. Mommy MD. If you don't, you need to follow her. She's awesome. And she analyzed the pain scores, number of pain assessments, and amount of oxycodone provided to Black, white, to women by race after C-section at UNC Chapel Hill. And what she found is that Black and Hispanic women were evaluated for pain less frequently. So this is the number of pain assessments. Here's white women with 10.2 assessments on average on postpartum day 0, compared to 9.5 for Black women. Had higher pain scores. So on postpartum day 1, 30% had a pain score greater than 7, compared to only 17% of white women, and received less pain medication. And so what this illustrates is that the processes of care are not the same, and women of color are having a less positive experience of their postpartum care. And so we need to look at these kinds of metrics and then understand why they're happening and formulate solutions that create more equitable care. However, health equity is bigger than the processes of care that we provide in the clinic. The Boston Public Health Commission defines health inequities as differences in health that are not only unnecessary and avoidable, but in addition are considered unfair and unjust. Health inequities are rooted in social injustices that make some population groups more vulnerable to poor health than other groups. So as an example, I want to take you back to Lyndon Johnson signing Medicare back in 1965. Some of you may know from health policy that Medicare had 3 parts. Part A was hospital insurance that was paid for by a Social Security tax, and that was the same across the United States. It was a federal program. Part B was a voluntary program for outpatient care. And Part C was a federal matching fund for states to provide medical care for low-income families. And you might wonder, why is the program for folks over 65 a federal program and the program for poor folks is a state program? Well, the reason is because of racism, that Southern white senators were not going to vote for a federal law that required them to provide healthcare to poor people who were predominantly people of color in their communities. And so Lyndon Johnson made a compromise. To understand this, I would urge you to read this fabulous book by Heather McGhee called The Sum of Us. She talks at length about the ways that racism has affected access to services for everybody. And she writes that Johnson's Congress conceded to leave whether and how to offer Medicaid to individual states in a compromise with racism that curtailed the program's reach for decades. So let's think about who loses their Medicaid coverage at 60 days after birth. The data show that uninsured non-elderly Blacks are more likely than whites to fall in the coverage gap because a greater share live in states that have not implemented Medicaid expansion. And if you look at most of the states circled in orange here, they are states in the former Confederate South, whose Southern senators in the 1960s were not going to vote for a federal program for those living in poverty. So this is systemic structural racism having its effects decades later. So you're a patient who's losing her insurance, and so she can't get the medicine she needs to control her hypertension, her diabetes. She is a victim of a policy that dates back to 1965. And I want to zoom in on what that looks like here in North Carolina. These are data from the Kaiser Family Foundation looking at the threshold for medical eligibility during pregnancy, and then for single parents who are no longer pregnant. And so what you see here is during pregnancy, someone earning 201% of the FPL. The FPL is about $21,000 a year, so $42,000 a year can get pregnancy Medicaid. But once it's been 60 days postpartum and there's not a baby inside of that mama anymore, the threshold for coverage in North Carolina is 42% of the FPL. That's about $9,000 a year for a family of three. Total, $9,000 a year for a family of three. So one has to be incredibly impoverished in order to qualify for Medicaid outside of pregnancy. And this, again, we would have Medicaid expansion except for Johnson's Compromise in 1965. Another really important example of the ways that structural racism impact the health and well-being of the patients we see every day relates to redlining. So this is an infuriating and excellent book called The Color of Law that discusses how the government deliberately, through specific federal policy, created and perpetuated segregation in residential communities. So the way that redlining worked was that banks would go and evaluate the quality of different neighborhoods, and they would say, there are too many Black people living here, don't offer a mortgage. And so what this meant was Black folks who fought in World War II who came home were eligible for the GI Bill, but they couldn't get a mortgage because no bank would lend to them if they lived in a Black neighborhood. And so whereas white folks who fought in World War II came home, got a house, accrued value, passed that wealth on to the next generation, Black folks didn't have that opportunity. And that plays out today in the median and average wealth by race. So the median wealth of a white individual is $134,000 compared to $11,000 for a Black individual. And this isn't just about education. Even when you look at folks with a college degree or a graduate or professional degree, there's a marked difference in median wealth. And that difference in wealth is directly attributable to the policies of redlining that were in place a century ago. So when the patient in front of you is not able to take an unpaid leave from work because she doesn't have money in the bank, in many ways, that's because of a federal policy that prescribed her ancestors from getting money in the bank. I think this also plays out when we think about our colleagues of color who are paying off med school loans, that they're likely to have a lot less money in the bank or a lot less money in their parents' bank in order to support them to pay off their med school debt. And that is a direct consequence of federal policy that kept Black folks from accruing wealth and enabled white folks to do so. And so I think it's really important to understand where these differences come from. It's not about who works harder or blah, blah, blah. It is about structural policies that have allocated resources unequally. Looking at this in North Carolina, I would encourage you to check out this fascinating website from the University of Richmond, which allows you to look at redlining maps of communities across the country. So this is a map of Asheville. And what we're looking at here is this particular neighborhood in Asheville back in the 1930s, and then the social deprivation index of that particular neighborhood in the present day. And when you click on that particular area of the map, you can read about the fact that there was an infiltration of Negroes generally on the report that was written by the banks back in the 1930s. And they talk about the sort of problems with this neighborhood. And when you look today at the rates of mental health problems, kidney disease, and high blood pressure, they are higher than in most neighborhoods in Asheville a century later. So again, so redlining not only affects wealth, it also affects health. And we need to appreciate that when we're seeing the patient in front of us who has chronic hypertension and has a BMI greater than 40, and we think, oh, why doesn't she take better care of herself? There may be structural reasons that it is harder for her to quote unquote take care of herself. And so it's incumbent upon us to appreciate that and understand that. I think when we think about structural policies, it's also critically important to think about parental leave. So this is a 2012 study that looked at the duration of leave taken by men and women after the birth of a child who were employed. And what's just beyond shocking to me about this data, and I go back and look it up periodically because I'm thinking maybe I read it wrong, 23% of women are back at work within 10 days postpartum. Now, many of us as residents or medical students or attendings have had a baby and had to come back to work at 6 weeks postpartum, which is pretty brutal. But 10 days, you're still wearing like the big pad and the mesh panties from the hospital and potentially passing clots. It's really hard to go back to work at 10 days postpartum. And it's really hard to breastfeed your baby if you are back at work at 10 days postpartum. And what's so disturbing about this from a disparity standpoint is those individuals the most likely to have paid parental leave are those who are in the highest income groups. So when we look at the distribution of access to paid leave, the highest income quartile has the highest access and the lowest income quartile has the lowest access. So in this beautifully written and compelling review paper, Adam Bertle and Stephen Bazurka say, the lack of policies substantially benefiting early life in the United States constitutes a grave social injustice. Those who are already most disadvantaged in our society bear the greatest burden. However, I think it's really important to appreciate that this is not about, oh, poor people who are victims, let us reach out our hand from on high and support them. Rather, the folks who are affected know the answers, and it's incumbent upon us to listen. This team of incredible women from California wrote a beautiful piece on the Black Women Birthing Justice blog a couple of years ago. And they say, there is no answer to solving this crisis that Black women do not already know. It is in their lived experiences and resilience that drives innovation and belonging. And we as stakeholders should take heed. So as we consider these structures that have adversely affected our patients and lump disadvantage upon them, our role is to ask them what would help and then do it, not to prescribe from our medical knowledge what we think the right answer is. I wanted to share a couple of books that I've read that have been really formative in my understanding this history and encourage you to check them out. Killing the Black Body by Dorothy Roberts was written in 1997. It is a searing description of the ways that Black reproduction has been controlled and coerced in the history of the United States. It also talks about the history of contraception, the fact that David Duke, who was a KKK leader, thought that Norplant was a great thing and it should be required for folks receiving federal benefits, and a lot of other really sketchy history that are important when we think about equitable implementation of services like postpartum LARC. Medical Apartheid by Harriet Washington steps through the really disturbing history of the ways that the medical system has exploited and abused folks of color in US history. And I think it's important context as we think about things like, why might there be vaccine hesitancy among communities of color? Well, they've got reasons. And I think this history is really important for us to understand. Fragmented Democracy by Jamila Michener talks about how the quality of folks' experience of Medicaid is tied to the likelihood that they will vote. And she looks at data from across the United States that shows that the more difficult and burdensome the interface with Medicaid is, basically the more disengaged folks become in civic life. And so poor implementation of Medicaid is a voter suppression strategy. And I think particularly in light of recent events around voter suppression, this is a really important read. Reproductive Justice, an introduction, outlines the history of reproductive justice and gives some really beautiful concrete examples of what reproductive justice looks like in practice. Battling Over Birth is a collection of interviews and focus groups with Black women in California talking about their experience of pregnancy, birth, and postpartum care. And it's a wonderful starting point for listening to the community. California is not exactly the same as North Carolina, but I think this is a great place to start to understand the perspective of the folks that we serve. And then lastly, Tina Sack's book, Invisible Visits, talks about the experience of middle-class Black women in accessing healthcare and the kinds of stereotypes that they have to counter and the steps that they take before they walk into a medical appointment to try to establish their credibility because they're battling these stereotypes that are unfortunately ingrained in many of us. And I think it's a really important perspective to understand. I was so excited to see this resource become available. This is a free online training offered by Think Cultural Health. It's authored by a number of leaders in reproductive justice and maternal health equity. You can do it over coffee on a weekend, and it really raises some brilliant and important actionable steps about how we can better engage with our patients and be more just in the care we provide. I think when I think about what might better healthcare look like, I often come back to this quote from Chanel Portia Albert, who is a birth activist in Brooklyn and a leader of Ancient Song Doula Services. She said that during pregnancy, birth, and postpartum, every woman should be able to say, I am seen, I am heard, I am loved. And I think it's really important to appreciate that being seen is not about being visualized. It is about being connected with and identified as an independent person of value. And so we can do that in really specific ways. We can sit down when we walk into the room. We can make eye contact with the patient. We can find out something about the patient that isn't in her chart. So she's not just year old, G this, P that with that, but a real person. And one way that I've found has really changed my experience of medical practice and has brought me tremendous joy and has helped me to really see my patients is to start the visit with what's going well for you. And, she's in her office, so she may have a problem, right? That might be why she's here. But if we ask for what's going well, first, it changes the dynamic because then I'm learning something about her that's important to her and that she's proud of. And it also changes the power dynamic because it isn't about you, supplicant person suffering, I, doctor, shall save you. It's about a conversation. And so I urge you to try that on. Sometimes when the patient's in the SICU after postpartum hemorrhage and intubated, there's not a lot of what's going well, but what's going well is she's alive, right? And she's getting better. So I would urge you to experiment with that in your clinical care. I think we also need to be really intentional about shared decision-making. So shared decision-making brings at least two experts to the table, the patient and the provider. The providers are experts in the clinical evidence, and the patient and family are experts in their experiences and values. So once upon a time, there was paternalistic medicine where I, doctor, would say, you patient, do this, and the patient would say yes, or the patient would nod and not do it, but we would just tell them what to do, right? And then we thought, well, no, we don't want to be paternalistic. We'll just say, well, would you like labetalol or nifedipine or hydralazine? Which would you prefer? Which is kind of a stupid question, right? The patient might have an answer to that, but just saying you pick, I'm not going to tell you anything, isn't that helpful? Shared decision-making begins by asking the patient about her values and preferences. So what's going well? What's important to you? When might you want to have another baby? And then we share information and recommendations that are aligned with those values. I use this slide a lot in talks, and a wise colleague from the West Coast looked at it and said, this is good, but it's not just the patient and the provider. It's often the healthcare team and the patient and her family. And particularly in communities that have experienced marginalization, they may want the support of their family to help them make these decisions. And so saying, get out of the room, I'm only talking to her, is not necessarily in the best interest of the patient. So recognizing that there's a whole context to her decision-making and having a shared decision is critically important. I want to close with a quote from Unlocking Us, which is Brene Brown's podcast. I highly, highly, highly recommend listening to this. It is critical to my soul. And back about a year ago, Brene Brown spoke with Austin Channing Brown, who's the author of I'm Still Here, Black Dignity in a World Made for Whiteness, which is also a fantastic read that I highly recommend. And Brene talks about what it's like when she gets called out. And she says, if I'm a decent human being and I believe it about myself, and I get called out on something I've done that's sexist, racist, homophobic, heterosexist, xenophobic, whatever I get called out on, I have a secret mantra. I'm here to get it right, not be right. I'm here to get it right, not be right. I'm here to get it right, not be right. And so if I have to get it right, I have to listen and learn. If I have to be right, I have to use my niceness and my decency to defend my behavior. And Channing Brown says, the work of anti-racism is the work of becoming a better human to other humans. That's what we are doing. Being called out, even though it feels terrible, nobody would argue that it's a feel-good moment. We are saying, I think you have capacity to be a better human. Would you accept that invitation? So I use this a lot. And, I'm in a leadership role. I'm division director for maternal fetal medicine. My team calls me out from time to time on a variety of things. And I have to stop. And instead of saying, well, that's not what I meant to do, and I'm a good person, and I'm here to get it right, not be right. I'm here to get it right, not be right. So I urge all of you to take that with you, to move with humility in the world, and help us to create a universe where, as Joy Perry, who's one of my sheroes, said, what would it look like for mothers to not only survive pregnancy, but to thrive? Thank you.